booked up Dr. Brajbala. I'll have to leave at 6:30. So it's okay for Dr. Archana to give her lecture first, then I can do it and I'll just miss the panel discussion.
Okay, whatever you like. Otherwise, we
Yeah,
almost
that's fine. That's perfect, I think.
So then I have to inform Bela again.
Whatever you say, my lecture is only 5 minutes because I normally give my guest, like, opportunity to speak more. So it will finish. So
Yeah,
whatever you say, no
both
problem.
of us are going to speak only for 5 minutes.
If
we
you
can have a
start
good
on time,
discussion.
then
Yeah.
Braj, I think we should be able to give platform to you by 5:30.
Yes, yes,
Yeah,
ma'am.
yeah, that will be perfect.
Yes, starting by 5, just ma'am, we will be starting.
5:30.
Jagrati webinar में हूँ बताऊँ बाद में.
And Dr. Archana, how many minutes? Like 20 minutes is enough for me to speak because
Gada has to join. Yeah.
Yeah.
Mm-hmm.
Anju ma'am,
who is your MOC? Who is your
Hi,
MOC?
good evening, ma'am. Dr. Bela Jain. Why she had not joined? I'm calling her. Bela join कर लो. We have to start now.
Yes, ma'am.
Okay. अच्छा बसे मैम का पहना है फिर गुंजन मैम का है ठीक है जैसा शेड्यूल था वैसा ही कर
चेंज हो गया
हाँ
अच्छा पहले ये था कि सेकंड सेशन है
हाय
मैम मुझे अभी उसका फोन आया कि आपका सेशन पहला है
मैम एक्चुअली डॉक्टर गुंजन को जाना था सो वी थॉट टू कीप हर टॉक बट मैम का छोटा सा ही है बसे मैम का
नहीं तो वो तो सुनना ही है मुझे
बसे मैम
ओके
चलेगा मैम चलेगा कैसा है मैम आपके यहाँ ग्वालियर में मौसम गर्मी है
मौसम हाँ बहुत अच्छी बारिश नहीं है
मैम लंदन में इतनी गर्मी थी हमें लगा हम तो इंडिया में ही अच्छे थे
आप तो घूम के आ गए बढ़िया
मैम भयानक गर्मी थी वहां पे
पर अभी तो हाँ न्यूज में भी तो चल रहा है कि फॉरेन में आजकल बहुत गर्मी हो रही है
यस मैम स्कॉटलैंड वाज गुड बट लंदन तो इट वाज हॉरिबल
ग्लोबल वार्मिंग इज इम्पैक्टिंग एवरीवेयर
Yes, madam. That's why environment committee should work. But environment committee ज्यादा कुछ कर रही है. Conferences में भी बहुत सारा पेपर वेस्ट होता है. डिजिटल हो जाना चाहिए.
हाय मनीषा कैसे हो?
बिल्कुल बढ़िया मैम.
बढ़िया.
So good to see you after a long time. Even ma'am is also there. Good evening ma'am.
हाँ good evening.
मनीषा आज खूब सारी रजिस्ट्रेशन करा लेना.
बस मैम आप है तो हम लोग बिल्कुल निश्चिंत हैं.
बस यही सब एक दूसरे को बोल रहे हैं. I think the number of
Hi Vibha ma'am
has to go
Dr.
down.
Vibha good evening. आप म्यूटेड हो डॉक्टर विभा.
डॉक्टर ब्रज बख्शी मैम को कोई लगा रहे हैं बख्शी मैम और
मैम से बात हो गई थी मेरी एक बार मैं वापस से इन्फॉर्म करती हूँ एंड सुदीप जी we will be starting in time.
Yes ma'am. It's 5 o'clock now.
Yeah, just calling Bakshi ma'am once. And गड़ा सर से भी सुबह बात हो गई थी सर ने बोला था he will join in time.
Dr. Brajbala.
Hi Dr. Vibha. Hi Dr. Jyoti.
Hello everyone.
Archana madam.
Dr. Vibha.
Hi.
Hello Dr. Jyoti, Dr. Anju.
Hi Dr. Vibha.
Hello.
Hi.
Am I audible?
Yeah.
Yes.
Audible.
Bella, you're audible. एक बार बस गड़ा सर को या तो आप कॉल कर लो मेरी सुबह बात हो रही थी सर से मैं बख्शी मैम को कॉल कर रही हूँ.
Okay.
डॉक्टर गुंजन से डायरेक्ट इंटरेक्शन आज हो रही है. हाय डॉक्टर गुंजन.
Hi Dr. Jyoti. Heard a lot about you.
Oh,
even मेरी भी डॉक्टर गुंजन से डायरेक्ट बात आज ही हो रही है.
डायरेक्ट बात हाँ. We'll all meet in Udaipur.
That's great na so that 3 states came together for this.
Absolutely. I think interstate karna is much better and we know each other.
Yes.
बेला सर से बात होगी गड़ा सर से?
सर ने फोन कट किया मैम।
अच्छा, मैं करती हूँ जो वापस। बख्शी मैम ओटी में है, मैम विल ज्वाइन इन बिटवीन। मेरे ख्याल से हम एक बार गड़ा सर आ जाते हैं तो शुरू करते हैं।
बिल्कुल बिल्कुल जी मैम।
सर ज्वाइन करना है ना वेबिनार? तो Basir ma'am, Gadas are also in some meetings, so shall we start? We will take.
हाँ, because उनको भी जाना है and we have to like, yeah, so we can start and they can join when they come. So yeah, let's start.
Okay.
Sudeep
Yeah.
ji, let's start.
Yeah, we make it live now. Start with the lamplight.
And Braj, you can start the, and
Yes,
then
yes, ma'am.
go
All
ahead
right.
with the scientific. Yeah.
Yeah, yeah. So, good evening, everybody. Respected guests of today, respected program director, all the faculties and delegates of this webinar. I'm Dr. Bela Shah Jain, an infertility specialist practicing in Indore, and I'm going to be your master of ceremony for today. On behalf of ISAR chapters of Rajasthan, MP, and Chhattisgarh, it is my absolute pleasure and privilege to warmly welcome each one of you for this webinar. This program brings together experts from all over the country and renowned infertility specialists to share insights on infertility management. We are delighted to have all of you, and I'm sure at the end of this webinar, we will have a lot of tips and tricks and take home points to improve our individual infertility practice. Like every academic session, let us begin by seeking blessings of Goddess Saraswati and the traditional lamp lighting ceremony. Sudeepji, can we please have the lamp lighting? Yeah. Wonderful. Thank you so much. Without further ado, let us begin. I would now like to invite Dr. Brijbala Tiwari, ma'am. Madam absolutely needs no introduction. She is the secretary of MP ISAR. She's the chairperson of FOXY Environmental Health Committee. She is the secretary of ISOPAB chapter of Indore. She has been the past president and past president of Indore OBGY Society. Madam has too many awards and accolades to her name, and on top of that, she's a very busy practitioner in Indore. I
Thank you,
always
Bela.
ask
Thank
her, how do you do all of it, ma'am? So over to you, madam. Please address our faculties and delegates.
Thank you, Dr. Bela, for your kind introduction, and good evening, all faculties and our guests for joining today's webinar. It's great pleasure to have MP, Chhattisgarh and Rajasthan together because we are having cultural bond with each other, and it's great to discuss with latest trend and what we are doing in our area, what the patient protocol in your area. All the basic things are everywhere together. So we are having topics today: basic evaluation of infertile couple by sonography, by some blood investigation image, and how we are going ahead with induction protocol for getting maximum response in our infertile patients. And we are having faculties from MP, Rajasthan, and Chhattisgarh. And I really sincerely thank Rajasthan chapter, Dr. Gunjan Jain, Dr. Vibhagar, Chhattisgarh chapter, Dr. Jyoti Jaiswal and Madhupita Agrawal for making this possible. And I think it is going to be great interaction, and we are going to learn a lot for our patients. So I welcome you all for this webinar. And uh, first we will welcome our guest, and then we will start with our scientific session. And I sincerely request everyone to vote and support our beloved Archana Base madam. And I feel she is the right candidate for President Foxy. So thank you so much. Over to you, Bella, for that.
Thank you so much, ma'am. I would now like to invite Dr. Archana Baser, ma'am. Uh, what do I introduce you, ma'am? Everybody knows you. She has been the vice president of Foxy in 2020, chairperson MP ISAR. She is the fellow representative of AICC RCOG West Zone. She is the joint secretary of ISPAT and organizing secretary of AICOG 2021 in Indore. And most importantly, she's our upcoming candidate for the Foxy presidential elections, which are in the next month. I would like to sincerely request everybody to please vote and support Archana Madam, and wishing you all the best, Madam, for your upcoming venture. Over to you, ma'am. I would now like to request Archana Baser, ma'am, to welcome our guests of this webinar.
A very good evening. Namaskar to all of you. I think I'm really, really glad that we could really build up this idea of three state webinars on our platform of MP ISAR. Last week we had a webinar with Haryana and Punjab chapter, and today we are with Chhattisgarh and Rajasthan. So we are really thankful to presidents and secretaries, Dr. Gunjan Jain, Dr. Vibha Garg, Dr. Jyoti Jaiswal, and all the faculties who have really agreed to join on this platform. My dear friend, Dr. Anju and Dr. Manisha, all of you who have agreed and who have come together on one platform. As Dr. Gunjan, when we were talking before just a start of the webinar, that it is good to have interstate so that we connect very well with our colleagues and we know what is happening, because the problems which we are going to be discussing here and talking, because each state has its own challenges and a different set of problems, and the patients expectations, though they are little bit similar, but they are different also. So really happy to be here, and I must thank my convener for this webinar, Dr. Brajbala. In spite of sitting in Scotland, she could manage to connect with you all and gather you all on the one platform. And special thanks to Dr. Bella, in spite of her recent opening of a new setup and very busy this week, she has agreed to do our MOC. So really very thankful to all of you. And I think we are looking forward for a great learning experience this evening. So over to you, MOCs, because our chief guest and guest of honor are held up. They'll be joining and we'll introduce them as and take their blessings as and when they come. Dr. Asha Bakshi, I'm sure all of us know, she is a legendary IVF specialist, and Dr. Gada, he's kind of a godfather for us, all of us who are practicing in this area, infertility. Actually, he was the one who brought me in ISAR in 2003. So if he has joined, I would love to have his blessings right now. Or otherwise, we can start with the scientific session, Dr. Bella and Dr. Brajbala.
I'm going to introduce her. Hello. So before starting our academic session, we shall be introducing our Rajasthan chapter secretary and CG chapter secretary. Dr. Bella, will you please?
Yes, ma'am, sure.
And chairpersons, I think chairpersons have introduced.
Absolutely, ma'am. So before we begin, I would like to extend a warm welcome to all our chapter secretaries and chairs. Dr. Gunjan Jain, ma'am, can we please have the CV on screen? Yes. Dr. Gunjan Jain, ma'am, started the Jain Fertility and Mother Care Hospital in 1997. She is the chairperson of ISAR Rajasthan. She's been trained in Germany under Dr. Tinberg and done her fellowship from Stanford University in California. And she's trained more than 500 doctors in infertility with more than 35 years of experience in infertility. I extend a warm welcome to you, ma'am. Dr.
Thank you,
Jyoti
Bella,
Jaiswal,
and
ma'am.
good evening to everybody.
Good evening, ma'am. Next, I would like to welcome Dr. Jyoti Jaiswal, ma'am. She is the professor and head of Department of OBGYN at JNM Medical College, Raipur. Madam is the Secretary General of Indian Menopause Society, Chairperson of ISAR Chhattisgarh Chapter, Chairperson IG, Secretary General of SOFC Chhattisgarh Chapter, and Secretary General of ISOPAV Raipur Chapter. I extend again a warm welcome to you as well, ma'am, Dr. Jyoti Jaiswal, ma'am.
Thank you,
Next,
Dr.
can we
Bella,
have
and thank you to Dr. Archana and all who are here. So, warm hello to everyone.
Good evening, Jyoti.
Good evening,
now I
Dr.
would
Rishada. Thank you for incorporating.
now like to invite Dr. Vibha Garg, madam. Madam is a consultant OBGYN and IVF specialist and director at International Fertility and Healthcare Center in Jaipur. And she's an honorary consultant also at Fortis Hospital, Jaipur. Madam is the secretary of ISAR Rajasthan chapter. I extend a warm welcome to you, ma'am. And now I would like to invite Dr. Madhuprita, madam. She's the Chief Consultant Fertility Specialist at Ashoka Advanced IVF Raipur. She's done her fellowship in reproductive medicine and IVF. She has certified training in diabetology and USG and vaginal surgeries. On behalf of the panel, I would like to welcome you, Madhuprita, madam.
Thank you, Dr. Bela. Thank you for the kind introduction.
Without further ado, we would like to begin.
Bela, I think Gana sir will join in some time. So, meanwhile, ma'am, shall we introduce chairperson for the first session then? Meanwhile,
Yes, please. Yes.
once I'm checking, sir had joined or not. Sir ने बोला मैं 5 मिनट में कॉफी पी के ज्वाइन कर रहा हूँ. ठीक है मैम, फिर पहले चेयरपर्सन को इंट्रोड्यूस कर. Bela, chairpersons को इंट्रोड्यूस कर
Yes,
दो
ma'am.
first session.
Let us begin with our much awaited first session. All of us want to listen to our first speaker. I would like to invite the chairpersons, Dr. Vibha Garg, madam,
Hello,
Dr.
everyone.
Manisha Vajpayee, madam, and Dr. Tabassum, madam. Again, Dr. Vibha, ma'am, she's consultant OBGYN and IVF specialist at International Fertility and Healthcare Center in Jaipur. Can we have the CV for Dr. Manisha Vajpayee, ma'am? Yeah, she is the head Department of Embryology and Research at Pacific Medical College and Hospital, Pacific Medical University, Udaipur, and she's the managing committee member of ISAR India. Welcome, ma'am. Can we have Dr. Tabassum, ma'am's CV, please? Yes. Madam is the Vice President of Raipur Menopause Society, Joint Secretary of SOVSI Raipur Chapter, and Treasurer SR Chhattisgarh Chapter. Welcome, Dr. Tabassum, ma'am. I would now request the chairpersons to take over and introduce our first speaker.
So, very good. Thank you, Dr. Bela, for your kind introduction. And it is really indeed a proud privilege to introduce our esteemed speaker, Dr. Archana Baster, ma'am. Indeed, she doesn't need any introduction. She is such a known name in our fraternity or worldwide. She is, but for as per decorum, I would like to
Just introduce in short. I think I'm being introduced
she is a
already.
distinguished she's a distinguished obstetrician and gynecologist, director at Akash Hospital Indore, and highly respected leader in women's healthcare. She currently serving as a vice president FOXI, chairperson of MPSAR 2527, fellow of representative of CCR COG West Zone Joint Secretary of SPAT, and she has held several prestigious leadership positions in FOGSI, ISAR, ICOG, AOFOG, a Guinness World Record holder and a FOGSI presidential candidate for upcoming year. Madam is admired for her outstanding academic contribution and her visionary leadership. Today, she'll be sharing her expertise on highly relevant topic, ultrasound in evolution of infertility, an area that plays a pivotal role in the diagnosis and management of infertile couple. We are delighted to have you with us, ma'am, and a very warm welcome. The stage is all yours, ma'am. We are keen to hear
Thank you. Thank you, Manisha, for the kind words. May I be allowed to share my screen, please? So, a very good evening again. And my topic is very simple. And this is just the role of imaging and evaluation of infertility, because I think we as a infertility specialist, or what I should say as a gynecologist, all should become a sono-gynecologist or sono-obstetricians, because it is very, very important. It is very important that we all learn to do our imaging ourselves, because that definitely improves the results of fertility treatment. I'm not going to go into much detail of anatomy of the layers of the uterus and histology view. I'm just straight away going to ultrasonographic anatomy. This is what you see in the sagittal view. You see the myometrium, you see endometrium, and you see the serosa. And these are the different layers of the serosa as well. What I always tell in my lectures on the ultrasonography, and especially when I'm addressing to the gynecologists who are trying to learn the ultrasonography and infertility practice, that you can see serosa by laparoscopy, you can see endometrium by the hysteroscope, but the myometrium you can see only by the ultrasound. And you know how important is the role of myometrium in infertility practice, or in the as such in the gynec practice, because majority of the gynec patient who come to us with abnormal uterine bleeding, they have either fibroids, or they have adenomyosis, or they have polyps. And it is important, and the blood supply to the endometrium comes through the myometrium. So it is important that we learn to evaluate the myometrium very well by the ultrasonography. And these are the different layers of the myometrium: inner junctional zone, middle layer, and the outer layer. And this is the normal anatomy, normal endomyojunction, which you see on ultrasonography. And look here, there is a loss of endomyojunction by adenomyosis. The uterus is globular in shape. You can say that there is a salt and pepper appearance or Venetian blind appearance. So there are NUSA guidelines to classify what is the grade of adenomyosis, but we are not going into that much detail right now. We are just trying that what is the normal anatomy and what is not normal on the ultrasonography when we are evaluating a patient of infertility by ultrasound. This is a normal endomyojunction, triple layer of endometrium, beautiful. That's what all of us like to see. Now, the other reason why we do the ultrasonography is assessment of follicles, to know if follicle is mature and is going to yield a good quality fertilizable ovum, to limit incidence of multiple pregnancy, one of the biggest complication of ovulation induction, and to see if endometrium is ready to accept an embryo. And this is a very good picture of dialogue between hormones and vessel. This is an ideal picture where you have, this is a physiology which we have read in our postgraduate and undergraduate days, that how the menstruation, the levels of the hormones, and how the follicles are growing. And on the day of ovulation, there is a, just prior to ovulation, LH peak, and then ovulation happens in the corpus luteum, and then there is a luteal phase. And this is how you would be doing the follicular monitoring. And now, since we have Dopplers with us, and in the Dopplers you can see the PI and the RI, and you will put colors around the follicle and seeing how the follicles, periphery of the follicle is surrounded by the blood supply. More than 75% of the circulation around the follicle, definitely it's going to yield a good ovum. So that's what you are doing. And now, how many scans you do in one cycle? We are offering the 4 minimum scans. People may have their own protocols. One is the baseline scan, that is the day 3 scan, do a enteral follicle count and ovarian volume. Day 7 scan, pre-ovulatory scan, and luteal phase scan. So these are the pictures of the scans which we offer to our patients. This is a day 3 scan where we do the enteral follicle count, measure the ovarian volume in the sagittal section, in the transverse section, and measure the endometrium. And especially if you are scanning the patient for the first time, do a 3D evaluation of the uterus, whether it's a unicornuate uterus, bicornuate uterus, or any other shape abnormality of the uterus. So it is important that you do a good pelvic scan, look at the uterus and look at the adnexa. This is the day 9th scan after you have given your ovulation induction medication. And this is the size of the follicle, how it is growing. And this is the day 14 scan where you are putting the color and see how the blood flow is going up to the middle of the endometrium Applebaum classification. And this is the blood supply around the follicle. And this is the luteal phase scan. Do not just send the patient here that yes, all the scans are done. Always check the luteal phase as well, because sometimes you have the luteinization of unruptured follicle and patient is not conceiving, and you will not know if you have not done the luteal phase scan. And this picture is there in my consulting. We have taken the printouts of this, and when a patient, we are doing the counseling, they are coming to us, we show them this picture that this is how we will be doing your monitoring. And you can take pictures, couple of pictures, one ideal monitoring, one not so ideal monitoring. So if the patient is not responding well to your stimulation, you can show them that this is how the picture is and this is what the picture should have been. So there's a comparative picture. I think pictorial display of the findings really helps patient in understanding. And if there is not a good response, definitely it really makes them understand better. So this is how we do our scans. And then you do the enteral follicle count. We all know less than 5 poor responder, more than 25 is a hyper responder. I've just brought one case here for all of us to understand the importance of a good ultrasound by a fertility specialist. Or if you're not doing your own scan, just ask your radiologist to do one good scan for a woman who is coming for fertility treatment. This has happened very recently. A man came with his wife's report and he said that I'm 30 years old, there's no comorbidity, average BMI, regular cycles. We are trying since 1 year, madam, but not being able to conceive, though husband had severe asthenozoospermia, and for that they have undergone 2 cycles of IUI. She was diagnosed with left-sided tubal blockage and hydrosalpinx on HSG after doing IUI, which I think should have been done prior to IUI. And husband came because they were advised IVF and wanted an opinion prior to that we are so young, we don't want to go through IVF, we have come to your opinion. I insisted on assessing the patient prior to advising any treatment. Next day, he came with his wife and we took a history and found that she had progressive dysmenorrhea, scanty menses, initially had pain on her left side and was diagnosed with some cyst for which she had taken treatment. And she recently started having pain on her right side as well. And we did a pelvic examination and found tenderness. So we decided to do a transvaginal scan, and these were her findings. Look at her findings. These are the kissing ovaries. This is a uterus. And look at this. So she's already deep invasive endometriosis, stage 4 endometriosis. So if you see her picture here, means ideally, if this scan would have been done, a diligent scan would have been done earlier, they could have picked up the endometriosis, treated the endometriosis, so this women would not have progressed to the other side with the endometriosis. If you see in this picture, there is not good follicles around this. So she may have a low AMH also, which we advise. This is a very recent picture of 11th June only, which we did. Her LMP was 11th June and we did scan. And then her AMH was also low. At the age of 30, her AMH was 0.68. So what I'm trying to tell here, it is important that scan well. And if you, those of you who are scanning can see that this is the ureter. We can see the ureter, though it is not impinged, but this is the ureter you can see. So you do a good scan, you can do diagnose a deep invasive endometriosis, and you can likewise give an advice to the patient rather than just directly jumping on IVF. She is not conceived on IUI 2 cycles, because a proper evaluation of the case is very important even before you recommend them IVF, because this kind of patient may not have a good outcome or good success result even after IVF. So this is like how the ureter is. That's what I wanted to show you, that you can pick up ureter in endometriosis if you have a good scanning acumen. And all of us who are scanning and you find a deep invasive endometriosis, please always do a renal assessment also to see if any hydronephrosis, because unfortunately I had to get nephrectomy done for one of my very young patient, 22-year-old, for whom endometriosis, deep invasive endometriosis was missed, and she had a ureter block and she had a non-functioning kidney. So I want you to leave this podium by asking, is it okay to miss an obvious diagnosis of endometriosis in this day and age of ultrasound and let the disease progress for want of getting a baby and without assessing it the pelvis properly? How would you proceed further? And should ultrasound be a part of initial assessment of every patient with infertility? So thank you very much for patience listening, and I hereby request you all for your support and for your vote. I am with you, I am for you, and I'm by your side. And I'm grateful for your trust over the years, and with your support, I'm advancing in FOXY together. Thank you very much, and look forward for your support. And if there is any question, I'm happy to answer.
Thank you, madam. May I request our chairpersons for their expert opinion in.
Thank you, Dr. Archana. It was a very, very nicely done, precise and very short presentation. And especially your last case of endometriosis is just an eye-opener. We all, we all do our own ultrasounds. I think the infertility specialists, they do their own ultrasounds, and it makes it so clear, because if you get an ultrasound done by the radiologist, they always say clinical correlation is important, and we have the advantage of doing it. When we are seeing the patient for the first time and assessing the patient, we have a very good idea of a pelvis. So it is very important to do a good ultrasound and assess the pelvis, the endometrium, the antral follicle count, and then also do the follicular monitoring yourself, because it does give you a good idea of where the patient is in a cycle and how she's responding to your ovulations. And ultrasound is most useful in infertility because it is non-invasive and it is easy to do. And it's not only this, it's also useful in tubal testing, also the endometrial assessment in IVF. Of course, we all do transvaginal ultrasounds and use Doppler and use ultrasound for embryo transfer. So ultrasound is the first and last modality we use in infertility. And without ultrasound, I think we can't even think of practicing infertility anymore.
Thank you, Vibha ma'am, for your comment on this ultrasound, because it is our stethoscope for infertility specialist. This is our stethoscope. So madam had just went in OT for some emergency. So we are having our guest, Dr. Dheeraj Gada sir. So I shall be introducing sir. It's my humble privilege to introduce none other than our patron, our guide for every obstetrician, every infertility specialist, not only in Indore, but MP and internationally. Sir is well-known figure, and sir is past president of ISAR, and sir was winner of Lifetime Achievement Award for both All Indian Society for ISAR and Indian Fertility Society IFS as well. Sir is the first in the state of MP to bring laparoscopy, hysteroscopy, ultrasonography, TVS sonography, ART techniques, including first test tube baby of MP, and he has touched lives of infinite families for more than 4 decades. And he is always there to support us, to guide us, and we welcome you, Gada sir, and we need your blessings. This is webinar for 3 states jointly organized by MPs in Chhattisgarh and Rajasthan. So we welcome you, sir, and we need your blessings. Gada sir? Sir had joined. Hello.
Ma'am, we can't see him right now.
Sir was there. That's why.
Yeah, he had joined. Yes, he had joined, ma'am.
He's there now.
He's there, but now he's on mute actually.
Okay, I'm calling sir again.
Yeah.
Someone can
Dr.
call
is
him
there?
to unmute.
Okay, sir. So, sir is there to bless us and
All right. I
sir,
think,
can you hear us? Gada, sir.
ma'am, he is still on mute.
Sir, you need to unmute.
Yes,
Yes, sir.
now,
Yes, sir.
now.
I can see you. Yes,
Welcome,
sir.
sir.
Sorry, I'm late because I was online with a court in Gujarat for one of my patients' evidences. So it took little longer. I'm sorry.
No issues, sir.
No issues,
we
sir.
are
We
eager to
welcome you.
listen your blessing, sir.
I'm very happy to know that you are organizing such a wonderful teaching programs. And I'm sure about Archana. She is very hardworking. I hope that all of you will support her to become the president of Foxy. All the best to everybody. Thank you.
Thank you, sir. Thank you, sir. Thank you for joining. Thank you so much, sir. Sir, this is joint webinar by MP, Rajasthan and Chhattisgarh chapter.
Yeah, I know. It's a good, very good work. I have seen the program. I'm already I'm just listening to everybody. Don't worry.
Okay, sir. Thank you so much, sir, for your blessings.
Thank you so much, sir.
Shall we proceed for second
yes,
session?
that brings us to the end of our first session, and we will now begin with our second session. I would like to invite the chairpersons for this session, Dr. Brijbala Tiwari, ma'am. She's the secretary.
I'm
and
already introduced.
yes. Moving on, welcome, ma'am. Dr. Pragya Suryavanshi, ma'am. She is the senior consultant OBGYN and director at SMC Super Speciality Hospital in Raipur. Madam has been she is the vice chairperson of Chhattisgarh ISAR, past secretary of Chhattisgarh ISAR, and ma'am has a lot of accolades and lot of rewards and recognition to her name. Next, we have Dr. Anju Verma, ma'am. She is the consultant infertility specialist at Dr. Verma Hospital and Fertility Center in Gwalior. She runs a Foxy recognized training center for basic and advanced infertility and affiliated training partner for clinical embryology with Vikrant University. I take this opportunity to welcome you to this webinar, madam. And we have Dr. Pratibha Makhija, ma'am. She's a consultant in ART and gynec laparoscopic surgeon, high-risk pregnancy obstetrician at Makhija IVF, Bilaspur. Madam has worked as an assistant professor at JNM Medical College, and she has done her diploma in reproductive medicine and embryology from Munich and advanced diploma in reproductive medicine from Kiel in Germany. It is a pleasure to have the esteemed chairpersons for this next session. I would like to now ask the chairpersons to please take over and introduce our guest for this session, for our speaker for this session.
Dr. Pragya and Dr. Anju, ma'am, will you please introduce?
Please show the slide.
Can we have
her introduction slide. Dr. Gunjan Jain introduction slide.
Sudeepji, can we have Gunjan Jain
Yes.
ma'am's slide,
Madam.
please? Introductory slide,
Yeah.
please.
So we welcome,
Yes.
she is very renowned, what we can see, and very had done very hard and heavy work in this IVF, which we can see that she has started Jain Fertility and Mother Care Hospital in 1997, and she is chairperson ISAR also, and trained in Germany under Dr. Tinnenberg, and she had followed fellowship from Stanford University, California, and she has trained more than 500 doctors, which is very big thing. And she is having more than 35 years of experience. So welcome, Gunjan madam.
Dr. Gunjan, you can share your slides.
So I'll just share my slides first. Meanwhile, thank you so much, Dr. Brijbala, for having me here. And it's a pleasure to be with Dr. Archana, who is our candidate for Foxy elections, and wish you all the best. And an honor to have Dr. Gada and Dr. Bakshi as the guests of honors here. Thank you, Dr. Gada, for being with us, because you are such a blessing for all the people who work in the field of infertility, because you are one of the go-to persons. I'm really sorry for my dogs barking. We'll just have them, because this is their time to be with us. So give me 1 minute to have them. So it was very nice, for Dr. Archana Base to make things very easy for me, because she's left on a note where it is dealing with low ovarian reserve, and there is a reason for the low ovarian reserve here, which is endometriosis. So now start taking this forward, So these are the patients who are young patients who have a low ovarian reserve, and for a very long time, probably their diagnosis. Give me 1 minute, please. Let me have him out. So for a very long time, the diagnosis of endometriosis has been missed for this patient. So looking into this, these are the patients, if they are picked up early, then things can be much better for them. So now going forward in this patient, she has come to us. We know she has endometriosis. We know that her AMH is 0.6. So how do we proceed in this case? So it is basically, first we have to have a very good counseling session with the patient, because at this age, having a very low AMH, as low as 0.6.
Your slides are not moving.
I have not moved them yet, because I was discussing Dr. Archana's case,
Sure.
So basically, so here we have two options in front of us. We have to discuss with the patient as to actually what she wants, because as Dr. Archana said that she also has hydrosalpinx in one of the tubes. So now this is a patient who cannot probably proceed without having a laparoscopic examination, and probably removal of the cysts if required, because now surgery has a very, controversial role here. If you remove the cyst, then you may have a further fall in her AMH. So sometimes, you have to give options to these patients, that if you want your egg retrieval and embryo freezing before we take you up for surgery, that is one option. And if she doesn't want any kind of an intervention in the form of IVF, because there are patients who are so young, they'll just say that we don't want IVF at any cost. So in these patients, probably then surgery, we have to put in a scope, we have to free the ovaries, because they're probably stuck in the pouch of Douglas. We have to free them. We should get rid of the endometriosis as much as we can, making sure that we leave as much normal tissue as possible behind, because she still needs to have her fertility going on, and she still has to have children. So every patient has, to be counseled, then we have to reach to a particular decision and then proceed accordingly. So if we talk of a definition of low ovarian reserve, it is a reduced quantity of the remaining oocyte pool. Now, according to the Poseidon criteria, we have taken this as AMH as 1.2, AFC as about more than 5 per ovary, and we go according to these criteria. But we have to remember that low ovarian reserve does not correspond to poor ovarian outcome. Like if we are stimulating, if we get a poor response, so poor responders are not synonym with low ovarian reserve. We may have a good reserve, but still they may be responding poorly, which is totally clear to us in the Poseidon criteria. The significance in our ART procedures is that because we are getting a low response, we have fewer eggs to deal with, we have more cancellation rate, and the treatment discontinuation is more in these patients because they're so tired of going through their procedures. We'll have a poor embryo yield, and a cumulative birth rate will definitely go down in these patients. But the importance is, that this does not lead to a poor quality. Quality is always determined by the age of the patient. So a 0.6 AMH at 30 is not the same as 0.6 AMH at 39. A patient who is at 39 will have a poorer response as compared to a patient who is at 30 years of age, because her quality will be determined only by her age, and there's nothing we can do about the age. Age reversal is just not possible as on date, but we really don't know what's going to come in the next 20 years because so much research is going into everything. So the burden of having a low ovarian reserve is going on increasing. This is mainly because of the lifestyle changes that are coming in, increase in the autoimmune disorders. There's something we have seen in our clinic after COVID. The incidence of autoimmune disorders has gone up. The incidence of having low AMH in younger patients has gone up. And the delay in marriages and delay in childbearing is adding to the burden of all this. So this is becoming like sort of a pandemic. Initially, we used to have very few patients, in 1990s, we used to have very few patients. They used to behave according to their age, but this is no more seen like that. At very young age, as young as 26, 27, we are already seeing low ovarian reserve. So dealing with it is something that we have to learn now. So we all know that the pool goes on decreasing. At menopause, we have almost 1,000 eggs left with us. And this is what, we are trying to do rejuvenation. This is the knowledge that we have, that some antral follicles are still remaining in the ovary. They are never like zero. We never reach to a count of 0. So that is what we are trying to use. But at puberty, we have around 300,000, but only about 400 are there available for ovulation. And when we discuss the causes of low ovarian reserve, we have to understand that age is the most important thing. According to age, it will decrease. We will have a lower reserve at a higher age, like maybe more than 35 as compared to younger patient of the same patient. If we have seen the patient 10 years back, her AMH may be late, say 2.4 that time. But now if she's coming to you after 10 years for another IVF, her sibling wants a sibling for her child. And sometimes they come to you after 10 years of infertility. So they are now going to have an AMH maybe of 1.2. So it is not a decreased ovarian reserve for her. According to her peers, she has a normal AMH. So age plays the most important role. Genetics and iatrogenic factors, like we just talked about the endometriotic surgery, chemotherapy, and pelvic radiotherapy. Of course, they are the known factors. Endocrine disorders definitely have to be looked into, like the thyroid, pituitary dysfunction, and autoimmune diseases are on the increase. We really don't know whether the lifestyle changes are causing. I had a word with the with our person who's dealing with all the autoimmune diseases, our immunologist, and he is also of the opinion that something has gone wrong after COVID, that more and more patients are presenting with autoimmune diseases. And the beauty of this is that the patient presents with a low AMH much before, you actually recognize that the patient has an autoimmune disease. Now, one thing is very important, the history in these patients. So take all the history. We do often ask, kabhi bachpan mein, did you have tuberculosis? Did you have any ailment? Did you have repeated UTI? Was there vaginitis? If there's any other problem, that the patient has had. But, concentrate, give a very, very detailed, take a very, very detailed history of her cycles. So shortened cycles, if she says that she had a 28-day cycle or a 30-day cycle, and now for the last few months, she started having a 22-day cycle or a 23-day cycle, this should ring a bell in our mind, because this is one of the earliest clues that we can have that probably her AMH is going down. So in these patients, whosoever says that, her response to stimulation was poor, we should again think and start evaluating the patient for a poor ovarian reserve and history of failed IVFs. If this has not really documented well, we should look into it. So we have two criteria, the Bologna criteria and the Poseidon criteria, and we are all very, very well versed with this. But Poseidon criteria has a little advantage because it helps us to follow certain strategies, about how to ovulate these patients again for IVF. But let me make it clear here that all patients of low ovarian reserve are not going to be taken up for IVF. They have a chance of a normal pregnancy. They have a chance of a pregnancy with IUI, and of course, IVF is the last thing that is offered to them. So any patient who's coming to us with low AMH, we have to see at what age this low AMH is being presented. So suppose there is a patient at the age of 28 and she has an AMH of 0.9 and she's just married for say about 6 months. They should be told, they should be counseled that they cannot delay their pregnancy forever, because sometimes patients come to us just for a pregnancy counseling, and they usually now tell us that we want to just wait, for the things to get settled in their life, the careers to be settled, and they definitely don't want a baby for the next 3 to 4 years. So now these are the patients who have to be told that, they don't have too much time. They have to plan their pregnancy early, or they have to now get into the mood of starting to think about freezing of their embryos, because it's not that once the embryos are frozen, they are bound to use only the frozen embryos. They can always go back to a natural trial. If that fails, then those frozen embryos can be used for having a pregnancy. So the counseling is the most important part when you see a patient of low ovarian reserve. But now if the patient is already 38, 39, 40, more than 35, and she has a low ovarian reserve, then according to the other factors that we might see, we have to decide either we start with IUI or go ahead with IVF earlier than younger patients, because these are the patients we really don't know, when the follicles are going to become lesser and lesser, and when are we going to have no follicles, that whatever we try, we may not get enough follicles. And I had the privilege of attending a lecture by Dr. Asha Bakshi, where she spoke on a very beautiful thing, how low is low. Because we have to decide, a patient comes with a AMH, say, of 0.6. Now, there are centers, who have a cutoff of 1. Now, I don't think this is right to do. If you have a cutoff 1, you cannot tell the patient to go in for donor eggs. There has to be a cutoff for every center. And our cutoff is usually when it goes into 0.0, like it's 0.09, 0.08, 0.06. But up to 0.1, we have had patients who have had their own babies. So it is always better to discuss with the patient and find out why she has come to us. There may be patients who will do anything, even for a 1% success rate. They are ready to go in for their own eggs. So they should be given the chance of having their own baby with their own egg and their own sperm. So now if we have younger patients with a normal reserve, but still a poor response, we do not label them as low reserve patients. But if a patient is young with a low reserve, we know that we need to hurry up with the treatment, whatever it is, whether it's IUI or IVF. Now, with older patients with a low reserve, definitely we have to proceed with the IVF sooner than other categories. So if we compare the Poseidon and Bologna criteria, we usually we use the Poseidon in our hospital because it gives us a very good tailoring for our protocols. So now investigations, Dr. Archana has beautifully told us how we go about with the AFC in the early cycle, which has to be taken up by day 4 maximum. AMH is totally independent of the cycle, though a few articles have come in where they say that AMH on day 2 and AMH on other days of the cycle may be slightly different, but they cannot be so different that our whole plan of treatment will change. When I started treatment, AMH was not there. We had not done AMH for a very, very long time in our practice. And FSH and LH were the only criteria that we used to use. And the cutoff that we would take was 10. If FSH was less than 10, we would tell them that, yes, you have a good chance of having your own eggs. But if the FSH was more than 15, then generally at that time, we used to tell them that you have a very poor prognosis of using your own eggs. TSH, prolactin, is done for every patient who undergoes hormonal workup. Now in ultrasound, we have already talked about it. AFC is one of the most important things that we need to see. And combining AFC and AMH gives us a very, very good indication as to whether we can have good number of eggs from this patient. The advanced tests are not meant for anybody. They are not like the first line of testing. But yes, if there is any history or there is any previous history or the sister is giving history of having low ovarian reserve, we must test this patient for karyotyping. So in the management, we first come to counseling. For me, counseling becomes the most important part because when we have already done our investigations and we have found out that according to her age, she is a low AMH patient or she has low AFC and she has a poor ovarian reserve, we have to counsel this patient. We have to give a realistic approach. We have to have a dialogue with the patient, including the family, if it is required, because sometimes you have to tell them to go in for donor eggs straight away. There is no point in, even trying with their own eggs. So the whole family sometimes needs to be counseled, whosoever they want to bring in, because it is only with the permission of the couple that other people are sitting in your room for counseling. Now, the most important thing is to give them a good percentage of success. We cannot tell them that you're going to have a 50% success, 40% success. Sometimes we work only on 4 to 5% success rates. And if the patients are willing, only then we proceed. And these consents should be taken in writing in their own words. Because sometimes, when you have done 2 or 3 cycles and still the patient is not able to conceive, somebody will tell them they did not understand anything. So it is always better to take a written consent on this in their own language, that they've understood everything. They've understood that, this much money could be involved because every cycle is going to have more cost burden on them and the kind of success that has been talked about. So they should give it in writing. The monitoring has to be very close. And if the factors, adjunct therapies like, treating them before or during the cycle, these have to be discussed. Suppose the patient is a smoker or there's a lot of alcohol consumption or both husband and wife are very obese and they are young and we think we have enough time, we can give full treatment for about 2 to 3 months, because half-hearted treatment here, like suppose we are using coenzyme Q, then giving it for 10 days, 15 days will absolutely not improve our results. We have to use it in an adequate dose and we have to use it at least for 2 to 3 months before we can start the treatment. There is no hard and fast criteria of using any therapy, but CoQ DHEA, they have been documented to give good results. A very low dose HCG priming is coming up as the new protocol that can be used, but no definite answers have come so far. The protocol selection has to be very good. We'll discuss these in a little while. And once it has been, everything has been discussed, we start with the protocols. So here I'm going to talk only about the protocols that we are using in IVF. So different protocols can be used. Antagonist is the most popularly used protocol, but now there is evidence coming that, you know, antagonist protocols is not the best. Microdose flare can be used, and we are even going back to the long agonist protocols for these patients. So in the antagonist protocol, we are trying to avoid any kind of premature LH surge by adding Cetrulix, which we all know. Microdose flare was very, very commonly used for the patients in, in the times we started practice, but just for those who are not using it very often now, agonist is given for the first 1 or 3 days, which pulls out all the FSH-LH, the endogenous one, and then you add your gonadotropins. So the dose of gonadotropin may be less, and the number of days needed for ovulation with exogenous gonadotropins may go down. A mild stimulation protocol was thought about because as it is, they don't have too many eggs which will come up. So a mild stimulation may reduce the cost in these patients and they may tolerate it better. Duostim was really, it became very popular, certainly say about 2 to 3 years back. But now again, people have started thinking whether we should actually use it as much as we are doing it for low reserve, because, the pooling can be done in 3 different cycles also. But one good idea about using Duostim is that you can do the first cycle in the luteal phase, second cycle in the follicular phase, and then do a transfer. If the patient is not ready to freeze everything and wants a fresh embryo transfer, then that is the only way to go forward. Modified natural cycles, we are not using it very often. LH supplemented antagonist, yes, there is a low dose HCG protocol that we are using very often these days. So what we do is we start with our FSH or HMG, whatever dose we have thought of, we start on day 2. After 5 days, we call the patient. And now if she has a follicle of say about 12 to 13 mm, we give a very low dose of HCG, which is about 200 IU. And here we can either continue with the same dose of gonadotropins, or we can even stop them or decrease them. Cetrulix may or may be added as required by the clinician. And these are giving us very good results in patients, especially the older patients with low ovarian reserve. And one more thing I would like to add here is that, these follicles may not go up to the 18, 19, 20 mm as we do it in a patient with a good reserve. Sometimes you have to give the trigger at about 16 to 17 mm. So we must take care of this. Otherwise, sometimes either the follicles will rupture in spite of using Cetrulix or any other antagonist, or we will have hypermature eggs. So both are not good for us. So we might have to trigger these patients a little early. So adjunct therapies, we have already talked about. DHEA, CoQ definitely have a role to play. Growth hormone, we are not very, very commonly using it because in Rajasthan, we cannot take the cycles to a very, very costly affair. So it is being used very, very minimally. Nutritional supplements, yes, they have a role to play. The diet, the stopping of any kind of a factor which is having a negative result, like smoking, vaping. Some people, they come to us that, we are not smoking, we are vaping, that leaves a very sweet taste in the mouth. Now, that is the trick why vaping is becoming very popular, but it is definitely worse than smoking, I feel. The emerging concepts of platelet-rich plasma, ovarian rejuvenation, stem cell therapy, mitochondrial transfer, they are all there, but PRP installation is being used more widely than others. It has given good results in some patients, but we cannot promise results in every patient. So I think it is very wise to, tell them very, very clearly and take a written consent if we are using it. Because sometimes, after the whole therapy is done and the patient does not improve or give rise, we do not retrieve many eggs, or the result doesn't come. In spite of a good embryo, the results are not coming. The patient is there to question as to why you did it. So a written consent saying that it is not a short therapy has to be kept in mind. So emotional support again is a very, very important thing, because there are women who are getting blamed for having a low ovarian reserve. It is not definitely in anyone's hand unless and until they are correctable disorders like lifestyle changes. Otherwise, we have to give them a very good emotional support. We have to share all the information, and always a shared decision making. We have to show them all the pathways they have, and we have to make a very conscious decision about what we are going to do further. So these are some cases which are not necessarily only poor ovarian reserve. They could be poor responders. So we'll just skip them here. And future directions are in the form of genomics, AI-assisted embryo selections, which can improve the success rate. And we can have ovarian rejuvenation therapies, which may be more widely used in the future, and growing emphasis on fertility preservation, because if a patient is with a low ovarian reserve at a younger age, we must at least make them aware of the fertility preservation techniques. It is totally up to them whether they accept it or not, but making them aware and guiding them into it is a duty of a IVF specialist when they especially come to us for pre-conception counseling. So management strategies we have already talked about, clinical insights we have talked, and the future outlook. We all have things coming up very, very rapidly, so we have to be very well informed, because most of the patients are already reading and coming. They have more knowledge than us because they have read so much about low ovarian reserve. So we must keep ourselves updated and know what techniques are available world over. We may be using it, we may not be using it, but yes, we should be able to guide our patients very well. Thank you so much.
Thank you, ma'am, for your elaborative
Thank you.
talk. May I request our co-chair to conclude and give their expert remarks?
Thank you, Dr. Gunjan, for such a wonderful, elaborative talk, and I think covering all the aspect.
Thank you.
This is
Thank you
very
so much.
emerging problem nowadays in our infertility center. So please tell me was one question that
Yes.
when you advise your patient for this karyotyping and fragile eggs whenever there is low ovarian reserve, because you said that if there is history in sister, but any other indication for doing all these fragile eggs and these all?
See, if we do it as it is, we will not be able to improve the results too much, because here quality also is going to be bad. So once we tell the patient that enough eggs also will not be retrieved and maybe the quality also gets compromised, we have to understand, the patient has to be made to understand that a decision on donor can be taken earlier. But if she wants to choose, because suppose the sister already has 2 children before, she is not a good donor for this patient, because if the sister also has the same problem, we should not take it from them, because low ovarian reserve can be sometimes genetically determined, and we should not be, using the donors from the same genetics.
And second question, you have asked about the protocols of this low ovarian reserve, that FSH along with SCG or HMG, when you are adding 200 international unit of SCG, low dose SCG.
Yes.
So
See, that depends on what protocol. There are centers who are using only HMG. They have never ever used a recombinant FSH or only FSH. So it truly depends on what protocol you are using. If you are very happy using only HMG, we use FSH to begin with. And sometimes with older patients, we add HCG or we give HMG in the earlier phase, because some LH supplementation is needed for these patients. So that is totally your choice. You may give HMG for 5 days. You may use pure FSH, you may use Gonal-F, you may use Polygraph, whatever company you are using, you can continue using that, highly purified, whatever you want. And once the key is that once the follicle has reached 12 to 13 mm, only then you add HCG. Though I have read papers where low dose HCG is being given as a LH supplement even from the day of start of induction of ovulation. But what I follow, I'm sharing with you that I started only when the follicles have reached 12 to 13 mm, not later.
Thank you very much. Very nice presentation.
Madam, there is one question in, like you said that about the PRP in the ovaries and cell. So how many cycle of PRP you give? Because we have to give it either laparoscopically. So what is your strategy in this?
See, if the patient is not willing for IVF at all, the better thing to do is a laparoscopy, because the ovaries, if they are shrunken, it is very, very difficult to go into those ovaries ultrasonographically. So there we'd like to do a laparoscopic, because you have to actually hold the ovary to get into the ovary and inject your
Someone has joined with 2 devices. Can we request to please check everyone? Somebody has joined with 2 devices. Please log off from one.
Is it okay now?
Yes.
Yes, madam.
So in these patients, we are doing intra-ovarian PRP using a laparoscopic procedure. But here, because the patient is not wanting any treatment, you should tell them that they can wait maximally for 6 months to 1 year. Because there have been reports where the patients have even conceived naturally after intra-ovarian PRP. Because, the first report we read on DHEA, if anyone remembers, it came in Fertility Sterility. It, really brought about a stir. And there they had only 5 patients where they used DHEA, and they reported that every patient became pregnant, even with the FSH of 47, 48. So that was like something that came like a stir in the whole IVF practice. But later we realized that it is not, a magical drug. So similarly, PRP it is being used by everybody, but it is still not a very, very well documented thing that every patient is going to benefit from this. But if we are combining PRP with our IVF stimulation and aspiration protocols, then when we aspirate the follicles, and once we have finished the aspiration, through the same needle, we'll inject PRP in the cortex. So that is an easier process. At least, even if there are 2 follicles, the ovary is a little bigger, and it's easier to go into that ovary during the process of aspiration. So that is where we are using it after doing a IVF. And in the very next cycle, we start with our next procedure and leave one more PRP inside. So that is, if we have accumulated enough eggs, that is fine. If enough embryos have been frozen, we are happy. If a third cycle is to be taken, then we are not doing any more PRP injections in the third cycle, though people are going up to 3 cycles of PRP injections.
Okay, great. This is good idea, really good idea. So we avoid the laparoscopy in such by this.
Yeah, but if the patient is not ready to go in for IVF, she doesn't want IVF, because still, in Rajasthan, as we said, we have a 3-state conference to discuss, what are the problems we face in our particular state. In Rajasthan, people still feel this is not normal. Like, if you tell them IVF ki zarurat hai, normal nahi ho sakta kya? This is something that they'll come up with. Not because of the money, not because they can't spend, not because they're afraid of the injections or anything, but they think that IVF is something, which is the last resort, which is unnatural. So they will not give a consent for IVF even if they need it, even if you think they need it. So these are the patients only where we select them for a laparoscopic installation of PRP.
Thank you, madam. Thank you so much, madam. It was such a nice explanation.
Thank you so much. I am really, really sorry I spoke to Dr. Brajbala, because I have a flight. I'll be leaving all of you right now. And I'm sure there's going to be a very, very good discussion on the panel discussion that we have. Thank you for having me here, and good evening and good night, everybody.
Thank you,
Thank you,
Dr.
Thank you. Thank you so
Gunjan. You
much,
have
Gunjan ma'am. It
already
was
decreased lot of work from the panel moderators. It was a self-explanatory talk, and the panelists will be more happy now to discuss about those things. So thank you so much.
Thank you so much. Yeah.
absolutely. I agree with Jyoti ma'am. I think it was a very informative, and ma'am has tried to cover a lot of practical tips when it comes to low ovarian reserve. So that brings us to the end of our second session, and now we head towards a very exciting panel discussion on stimulation protocols in IVF.
Do we have any input from Dr. Pradya also?
Ma'am, there is somebody is has somebody logged in from two devices? I think
Maybe with mobile as well as laptop.
yeah.
So
Veronica ma'am, can you please check? Because I think when she is unmuting, there is some sound.
Veronica was
No,
having some problem in joining also. So maybe
no,
the two devices.
I have joined only through the, I don't know, through the laptop.
Veronica, once open your phone and close off the phone once. Close all the apps running and then recheck, please. Sometimes in the background it is running and we are unable to identify.
Yeah.
Because when you are muting yourself, then problem is going.
I think now it is better. Yeah.
No,
So
but now my
it's there again.
Deepti, can you check from where it's
It is,
coming?
I
it's
have
logged
switched
in.
off my phone.
I think it's logged in two systems. Dr. Veronica has two
Anyone you
systems.
can detect.
Two systems it is. One you have to log out.
You can clear all the apps, Veronica.
Phone.
I think it's clear now, na? You can start
No, she has
introducing.
not joined, I think.
So meanwhile, you
Is
start.
Dr. Veronica there? Yeah.
Hello.
Okay.
Yeah. I'm back again.
Hello, ma'am. Hi.
Welcome everyone. Welcome everyone. You have an obstetric practice, you run a hospital, you can't run away from your patient.
It makes us multitasker, madam.
Yes,
Everybody is doing something or other sideways, so it's
I
all
know.
right. We understand.
Okay, so shall we begin with the panel discussion? I would like to take the opportunity to invite our moderators for this panel, Dr. Jyoti Jaiswal, madam. Madam is the professor and HOD of
Thank you,
department.
Bila. Thank you. You have introduced me earlier as well. So I am introducing myself once again that I am from Chhattisgarh chapter, and here as moderator, I have my co-moderator, Dr. Madhuprita Agrawal. She is the secretary of Chhattisgarh chapter ISAT. We have two experts with us also. Dr. Neeraj Palajani, a renowned senior IVF expert from Raipur itself. And we also have Dr. Sanjay Makwana. Dr. Sanjay, can we see him here? Dr. Sanjay Makwana is also expert with us. For the panelist, we have Dr. Navdeep Kaur Ghuman, Dr. Supriya Hazela. I know her, she is from Bhopal. And Dr. Veronica Irene, she is also a senior infertility practitioner from Raipur. Dr. Shivani Joshi and Dr. Kalyani Shrimali. So can we have introduction of the panelists from themselves so that we can see them on screen and we can connect better?
Shall we begin with Dr. Navdeep Kaur, ma'am?
Bela, you can check from
I'm
the
just
list that Dr. Navdeep is there or
no,
not.
she's not here,
I
ma'am. Let
I
me
could
just
see Dr.
reconfirm with her.
Dr. Supriya Hajela. Supriya, please, can you open your... Yes.
Good evening,
So,
ma'am.
introduce yourself, please.
Hi, I am Dr. Supriya Hajela. I've been practicing infertility since more than 10 years. I have my clinic running and we have a multi-speciality hospital, and it's really my pleasure to be on this panel and have a very nice discussion. Looking forward to it.
Thank you, Supriya.
Thank you,
Veronica,
ma'am.
could she join again?
Yes, I'm there.
So I introduced Veronica as that she is a senior IVF expert working since long in Chhattisgarh, Raipur, and she is vice president of Chhattisgarh ISAR too. So I know her personally, so I can introduce her. Dr. Shivani Joshi, can we have you on board?
Ma'am, Dr. Shivani Joshi, ma'am,
Shivani
could
seems
not
some
join,
emergency, so
unfortunately. She's stuck
So
somewhere.
Dr.
She could
Kalyani
not join us.
Shivali.
Yeah, hi, good
She's
evening, everyone. I'm here, Dr. Kalyani here.
Hi, Dr. Kalyani. She is from Indore. I
Right.
just know about her, but wish to listen more about herself
Bela,
from...
can you introduce Dr. Kalyani? Bela?
Ma'am, I'll just introduce myself. Thank you so much.
Okay, please.
I work as a senior fertility consultant with Nova IVF Indore, and I have been in the field of infertility for almost now 18, 19 years. And yes, I'm looking forward to this panel discussion. Thank you.
Ma'am is one of the leading IVF practitioners in Indore.
Indore
And a
is a hub
great
for the
friend.
IVF practice, and similarly, it is true for the Raipur as well. So, welcome, Dr. Kalyani. So, Dr. Madhuprita has already shared the screen. Madhuprita?
Yes, and do we have expert Dr. Neeraj and Dr. Sanjay with us?
We have Dr.
Neeraj
Neeraj
ma'am
ma'am
has
with
joined,
us.
I think.
I'm here.
Yeah.
Yeah, she's there. Okay.
Can we have a hello from Dr. Neeraj if she is here? Or Dr.
Yeah,
Veronica?
hi.
Hi, Dr. Neeraj. So I have introduced her that she is a well-known practitioner in field of infertility and working since very long time in this particular field and have a very good name. She is a renowned infertility practitioner from Raipur. So she is our expert today. Dr. Sanjay is not there, I hope so.
Yes, ma'am.
Has
Sir
he
has
joined?
not joined yet.
So
No, he's
anytime
not
if he
joined yet.
join, let us know. Let us know.
Absolutely,
And
ma'am. Absolutely.
Madhuprita, my co-moderator, infertility expert from Ashoka Hospital, and more importantly, the secretary of Chhattisgarh ISAR, a very dynamic and a young energy and talent she has. So, Madhuprita,
Thank you so much, ma'am.
can we start with the panel?
Yes. Can you see the screen?
I can
Yes,
see,
I have
but you
already
can make it full
shared.
screen.
Yeah.
Yes.
Now it's full screen?
Not yet. Now, yes.
Yes. Okay.
Okay, so this picture showing Louise, the world's first test tube baby, the super baby, but it was not with the ovulation induction protocol for IVF with a higher number of ovum to be retrieved. This was from a natural cycle, a single ovum and pickup and a single embryo transfer. This was the result of the Louis was a result of this. But in current scenario, we are not able to think like this, and we need to choose a protocol which is required according to the need. Madhu, you can just move on the slides. So nowadays, ovarian stimulation in IVF is depending on various things. So can I have from my panelists that how they individualize the ovarian stimulation protocol, because it is nowadays the most important determinant for our IVF outcome. So how you select your protocol, how you customize, how you give the stimulation, and what strategies depending on what factors. Can we start with Dr. Supriya?
Yes, ma'am. Ma'am, there are various factors on which we decide before starting the protocol. They are like the patient factors, which include the age of the patient, the duration of infertility, any other comorbidities like endometriosis or any gynecological conditions. Apart from this, we also try to assess the ovarian reserve of the patient. That could be done by measuring the AFCs on the baseline scan and knowing the AMH values. Apart from this, also we try to find out whether the patient has already undergone previous IVF cycles and what were the outcome of that. And that would help us customize the protocol for the patient. Apart from this, also the male factor can be taken into consideration before starting the protocol treatment. I think that summarizes most of the things before starting any IVF protocol for a patient.
Thank you, Dr. Supriya. Dr. Neeraj, anything to add?
One thing that before selecting, we need to take into account pelvic factors too. See, if the patient is a case of endometriosis or chronic PID or has a history of tuberculosis or has undergone ovarian surgery or tubal block or tubal recanalization, all these will also affect the choice of protocol as well as the dosage of the gonadotrophins. Rest all, doctor, you have covered very well.
And apart from that, sometimes the urgency to have a quick ovarian retrieval and like that, then that anytime if you have the urgent need, like cancer therapy for the patient, if patient has to go for that kind of emergency. So in that case also, like a pull up kind of thing, you will not be able to do. So in that particular situation, you need to modify your protocol.
And also, if there are estrogen sensitive tumors, then we have to change our protocol. Like we would want the estrogen levels to be low during stimulations. So these are all the conditions which we have to keep in mind before we start the stimulation.
Yes, and definitely, as Dr. Supriya suggested, that there are some biomarkers. She talked about the AMH and AFC. Yes, they are the very important. And as Dr. Gunjan was telling that in earlier years, they were not using the AMH and AFC, but nowadays it is important to have this also apart from the FSH, LH basic level. Next, please, Madhu. So the most valid starting dose predicting factor among all these response is also depends sometime looking at the previous cycle responses as well. So for prediction of the previous cycle, the AFC and AMH nowadays, they are the most important one. And no matter what ORTs you are taking, ovarian reserve testing you are taking, the long studies, they suggest that ongoing pregnancy rate after IVF does not get affected much. It is the age and BMI. That is the most important aspect. So now, when we are categorizing, like according to Dr. Supriya, we have categorized that these are this kind of patients. So how you can, we have to tailor made. Some may be poor responders, some may be normal responders, some may be hyper responders. So how you categorize your patient, how you say that this patient is like this and we need a different type of protocol, and what kind of protocol will be required in the hyper responder, what for the poor responders. This can be answered by Dr. Veronica.
Usually what I do, and I have been following, I have been actually strictly doing a monitoring depending upon the first baseline scan, which I prefer to do it on day 2 of menses whenever the patient comes. And deciding the protocol is her response in the previous cycle. If she has had, one factor is that. And the other major and the most important factor, which I feel, is her weight. And the third thing is her antral follicular count or AMH. AMH may also differ in different cycles. However, antral follicular count I consider the best. The best modality to take them, categorize them into either hyper responders or normal responders or poor responders. So antral follicular count is one along with her weight, BMI.
Okay.
These are two important factors which I usually consider when I take them. And then other associated histories, like suppose at times this is purely my personal this thing that I have seen, that if they have not responded in the previous cycle, at times changing the protocol also helps.
Age, AFC, and
Yes.
BMI according to that, and the response to
previous response,
Madhu,
what we
next
have
please,
seen.
the previous response according to that. So
Yes,
may I request Dr. Madhu to please
Yes.
put up first case?
Yes, so with this, we come to our case number 1. So this is a patient with, she is of 30 years age. She is for IVF. Her AFC and AMH seems to be normal. AFC is 14, AMH 2. She did not had any previous stimulation. You started giving her with RFSS 225 international unit. But the end, you could find that FOI was less. It was only 6 oocytes. So with this, I want to know from my panelists, do you use Poseidon classification? And if yes, for the benefits of everyone, can you summarize it? Anyone?
Dr. Kalyani is there.
Yeah, Dr. Kalyani.
Yeah, so Poseidon is the newer criteria that we used to follow apart from the Bologna. Bologna was the initial part which we used to follow for the decreased ovarian reserve, and now what we follow is the Poseidon. So Poseidon is basically divided into 4 categories. One is the age less than 35, the other is more than 35. In group 1, group 1 and group 3 is where the age is less. The first group is age is less than 35, but the antral follicle count is okay, like more than 5, AMH is more than 1.2. And the subgroup is A and B, where we are expecting that we are going to have poor ovarian response. Group 2 is where the age is more than 35, AFC is more than 5, and AMH is also more than 1.2, with subgroup of A less than 4 antral follicle, and B is 4 to 9. Now, on the contrary, when the age is the factor, less than 35, but the AFC is more low on the lower side, that is less than 5, and AMH is also on the lower side, that's group 3. And group 4 is more than 35-year-old and expected that AFC is less than 5 and AMH less than 1.2.
So in short, you can say that group 1 and group 2, they are unexpected poor responder because they were having good reserve. In spite of that, they are not getting good response. And group 3 and group 4 were expected poor responders.
Correct.
So initially we were using Bologna criteria, but they had some lack in some aspects, like they were not correlating well with the age, and there was no differentiation between hypo responders and poor responders and expected poor responders. And Poseidon gives us approach. We can stratify our patient, we can tailor make, we can personalize gonadotropin dose according to it, and also we can have some clue regarding the polymorphism of gonadotropins which these patients can have, and we can likewise stratify our patient and can manage accordingly. So can you tell me what is FORT and what is FOI? Dr. Supriya?
FORT is, I think, pre-ovulatory follicles divided by AFC into 100, and if it is more than 50, then probably it is a normal responder, and FOI is follicular oocyte index, I think, and that is also again more than 50. It suggests that it is normal. I mean, the patient is normal responder.
So basically, this is that initially when we look at the sonography at day 2, 3, when AFC count is very good, but even then we are not getting good results afterwards. So this comes for the FORT, and if the initial is also initial, whatever number is there, whether the good number of follicle is there or the lesser number of follicle is there, if the retrieval is less than 50%, so they come under FOI, isn't it?
Yes.
So
Follicular to oocyte index is less than.
Yes. Next slide, please, Adhuprita.
So what can be the possible reason for this low FOI. Like in this patient, we are having 14, but we got only 6. So according to you, what can be the reasons for it?
And which posidone class this patient will be categorized in?
She is in 1B. She's less than
She's
35 with oocytes of 6, that is more than 4, then she becomes 1B. And probably she might be having some FSH receptor dysfunctions that she did not respond well. And she fell into the category of
Okay.
unexpected.
Anything else,
responder.
Dr. Veronica? Veronica, ma'am, you can add here.
or Dr. Kalyani can also add.
Yeah, maybe even the trigger is a little mismatch. Maybe the trigger was
There can be
suboptimal, or
some.
maybe
She may
yeah,
also be
maybe.
belonging to those subgroup of patients which require a little bit of LH right from the beginning.
Yes.
She has
So
been
yeah.
stimulated by
Correct.
recombinant FSH purely. So this is a group of patients who require a small dose of LH which can be added from the beginning. And that can be done
And
usually
yeah,
2:1,
so sometimes what
but
happens
I
when we give
prefer.
the trigger on the day of the trigger, actually we are used to doing is only the estradiol and the progesterone level.
Yes,
Idea
and
should be to do the LH levels also. At any point you feel if the LH is less than 1 or less than 1.5, adding up an HCG trigger along with the agonist trigger would be a good idea. And maybe that
yes,
could give us
dual
a better
triggerism.
response. Yeah, that can give us a better response in the egg retrieval. And yeah, sometimes even doing the egg retrieval timing, maybe 34.5 or 35 may be early for her. Maybe postponing in the next cycle for this patient may be advisable. Maybe 36 or 37 hours is what we can do, karke.
Yes.
Yeah,
So there
also
can be trigger issues as well. So this happens mostly in cases of patients like donors. If they are in long OC pills and prolonged suppression, their LH levels might be less from the beginning. And if you give only agonist trigger and LH levels are less, then you might not get such output. So you should be very much cautious when you deal with the donors.
So the crux is that you have to go back and search that what could be the cause. Maybe in some thing can be in the history, and something maybe from your workup and the protocols which you have choose. So you have to once again think properly before proceeding ahead.
And doses can also be inadequate. What doses you have begin with might be she is the candidate who required more dose next time. So retrospectively, you should know their case papers, their profile, and next time you can. Would you like to shift the protocol next time? Like if you have used antagonist, so
that can be done because antagonist, though what literature says is that usually it's a safer protocol. Now when it comes to the oocytes retrieve, definitely some amount of oocytes less are always less in an antagonist protocol. So next cycle it will help you plan that you can change the protocol and see. You can do
yes.
that. There are other protocols also, like shorter protocols or agonist short protocols or flare protocols are also there, where they use a very small dose of agonist in the initial 1 or 2, 3 days of menses. So that will cause a higher rise in the FSH, and this will lead to more number of follicles. That can also be done.
So Dr. Neeraj, would you want to add something? Like if you have done antagonist protocol this cycle, so would you like to shift to agonist? What are your views on it?
Antagonist protocol cannot be generalized applied to anyone because the only issue as far as stimulation with antag protocol is concerned is the discoherent growth of the follicles,
Yes.
which is most of the time responsible for low FOI. So for all these cases, the best practice is to scan the case on day 2, day 3. And if you see that there is any follicle more than 10 millimeter in size, or if the LH levels are not up to the mark, then to get a synchronized cohort, we can give antagonist in the first 2 or 3 days and then start stimulating. So maybe if I'll take up this case, I'll go back and see whether this was the issue, dysynchronized growth, or at times in young cases only FSH that has already been covered. FSH is not sufficient, so maybe next time I'll take a combination of FSH and HMG, and Otherwise, if the patient is ready, the oocyte yield is always better in long protocols. So it is like we are following a loop. Initially, it was like a long protocol is good, and then it was NTAG protocol, and it worked really well for 5 to 7 years. And now again, we are back to the long protocol because there is better synchronization of the follicle, and with good freezing protocols. Nowadays, many centers, even if there are cases which are not so suitable for long protocol, they are switching again to long protocol because of
Right.
ease
So,
of
In a
patients
nutshell,
as
it
well
is
as
not
ease of
always
patient.
that antagonist protocols are right for each and every case.
need to
Rather,
individualize.
antagonist, agonist, depending on the, like you rightly said, Dr. Neeraj, that when you are going back to the and reviewing the case, you will be able to identify, and even the antagonist protocols and agonist protocols and the longer protocols are having the similar effect as the antagonist protocol. So after
And
reviewing
very
the
well
case,
pointed
any
out.
shift, Dr. Supriya, any shift in triggering?
Ma'am, we can shift to dual trigger so that we can have a better, more mature oocyte and higher number of embryos which are formed, and that might lead to improved implantation rates. So just going in for a single trigger, we can shift to dual trigger with agonist
Dual
and
trigger, dual trigger, if you are thinking of transferring in the same cycle, definitely it
then it
is
has to be avoided.
beneficial.
Then definitely it
No,
has
no,
to
no.
be avoided.
In fact, dual trigger is good if we are
But
thinking
then you
of
have to give
transferring
good.
in the same cycle, provided we are ruling out the OHS, because HCG is required for the luteal support. So that way, dual trigger is good. In this case, if you feel that the GVs were more, then maybe we will think of, because the yield is there. The only thing is we are not the picture is not clear whether we were having only 6 follicles and 6 M2s, or it was like the we aspirated maybe 12 follicles and 6 were M2s and the other were GVs or M1. In that case, we will think of maybe switching over from the agonist to dual trigger. Otherwise, if the yield was say 6 M2s out of 8, or maybe 9 follicles or 7 follicles, then change of the trigger will not do much benefit to the patient.
Yes. So before going for the dual trigger, we have to see the rationale. Madhu, can you summarize, please, this
Yeah,
slide?
basically what happens is in dual trigger, we are using agonist. So agonist, we have both the peaks, which is more physiological. We have LH and FSH surges both, and HCG is only LH surge. So giving dual triggers in any of the case where you are not suspecting OHS, you can very well give, and it gives a better outcome.
So I'm reading the second case. The another lady, she is not a very young one. She is 35 years, married for 6 years. AMH is also low, that is 1. AFC 7, right 4, left 3. TSH, say borderline, not exactly the clinical hypothyroidism, but yes, 3.9. Other investigations normal. She has some male factors, so donor semen IUI has done for 2 times and it was failed. So now, which protocol you like to use in such patient who is having long marital life, age 35, and the AMH is 1, Dr. Veronica? Duostim or biostim, what you will use here, or any minimal stimulation with embryo pooling you will like to have? Actually, What will be the
I have a personal
protocol you
experience
will
with.
like to?
I would like to go on for pre-treatment with OC pills followed by a low dose stimulation and embryo pooling. In such patients, I would like to collect whatever embryo. I have had very poor response with dual stimulation. I have tried in couple of patients, lots of patients, even in cancer patients who have come to me where they are really in a hurry and time is less and we have to collect as many embryos as possible. So it never worked for me and I stopped. So what I preferred is give them a low dose stimulation
अगर time है, so you can give a pre-treatment with OCs. Otherwise, do a consecutive cycle or and embryo pooling, which patients also agree to it. बहुत ज़्यादा stimulation भी नहीं करना पड़ता है, and we get good euploid embryos out of that. This is what I follow and I do. Dr. Shimali, your take on this? If Dr. Kalyani Shimali is there, she can give her. And Dr. Neeraj, we can take have your take also on this.
You are muted, ma'am. You're muted.
Neeraj, please unmute.
Unmute.
No dual stimulation, no bistimulation. In dual stimulation, we can go only for one reason if the time is short, and there is a trick to get a good response in dual stimulation, that we need to catch the wave. And for that, it depends that what was the first stimulation and what was the prep of the cycle. So it is better that until or unless there is hurry, as has been rightly mentioned, it's better either to go for mild stimulation with pooling of the embryos or a standard long protocol. In India, anesthesia and laboratory is not that an issue. Medicine is also not that an issue. So if we say that we'll go for mild stimulation with pooling of the embryos, there is not much of financial advantages, especially in tier 2 towns. So patient need to be counseled very clearly that they can have a yield with a long protocol if they are willing to accept that, or if they are willing for multiple retrieval, only then mild stimulation with pooling is good. And as far as OCP priming is concerned, I would like to have a different opinion with Veronica. Maybe she is having more experience in that. In fact, OC pills can give more number of eggs, priming of OC pills, but the aneuploidy rates go high with the OC pill, and that was the reason that people started rethinking of that whether we should give OC pills or not, because in the initial days when the IVF was done in batches, OC pills were used left right for batching of the
We'll be
IVF
coming
cycle.
to OCPs
And from
later on in the slides,
No,
because
no,
we
here
have the
the
in
use
slides.
of
this
OCPL
priming,
is not for batching. It's not for batching. It's for priming. Nowadays, the priming methods have also come.
this is what I was telling, that in
Progesterone
low
prime भी
ovarian
आ गया है.
reserve, in
But
low
we have
ovarian
randomized
reserve, use
trials
of
on
OC
it.
pills may increase the number of eggs, but it will increase the aneuploidy rate.
So let's see about the
And the
evidences.
idea
What
of
the
this came
evidences say.
from that batch use of OC pills in the batches. This was
So Madhu, please put up some
So,
evidences regarding
yeah,
this.
dual stim, as rightly pointed out by Neeraj ma'am, that we can go for it if we have limited time, like in cancer patients, and we have to, we have better protocols than dual stim. Like we can go for bi-stim also, like two conventional stimulation in two different cycles, and it has been shown that cumulative live birth rates and even M2s were better if you go for bi-stims. And now people are also doing like this, like they are starting stimulation in the luteal phase, and again they are doing the stimulation in the next follicular phase, so that they can have the advantage of doing a fresh transfer if required. So these protocol can be applied only on individual basis, not as a routine. And also, and if you really think that the cohort is getting asynchronized, then maybe agonist protocols are the better one. So any pre-treatment would you like to go for? Like if you really think that the patient is in desynchronized phase, and on day 2 she's having follicle like 13 or something like this. So do you like to do pre-treatment? Anyone? Dr. Kalyani? She's not there.
Yeah, so ma'am, I normally don't do so much of pre-treatment for a better cohort because nowadays we have shifted more to random stimulations rather than doing the day 2 or day 3 stimulations. So depending upon, yes, but if we have a previous patients who have had a failure, probably in that case maybe we advise for a pre-treatment. Initially we used to do a lot of testosterone gels, but we have stopped using according to the newest guidelines that it's not helping us more. Similarly, with the pre-treatment with the estrogen also, I do give it for some patients where, there's a low ovarian reserve. Maybe in those patients, it may help us in a better way for the better synchronization. And if it's a long protocol, normally I don't give any pre-treatment for these patients.
Right.
Also, it
So
is
you are
absolutely no-no.
going for random stimulation, random protocol as a routine, or in some
It,
specialized cases?
yeah, so it all depends because nowadays I believe in doing most of the time 99% of my cases are all free cycles. So if it's an all free cycles counseled that way, then probably I would like to do a random stimulation, maybe
So
follicular.
have you found any difference like in conventional and in random, like more gonadotropins you are
Only in
requiring or
cases, so
output?
when I do the luteal stimulation, I normally put the patients on the PPOS because maybe, if I've started, let's say on day 22 or day 23, maybe she may start having menstrual bleeding. And then, in the Indian scenario, the patients get very panicky that, I started bleeding and we are still undergoing the IVF
Yes.
cycle. So usually in the luteal phase, I prefer putting the patients on the PPOS protocol. And in that case, I have seen that the stimulation may go a little longer, maybe,
Yes.
day 12 or day 13.
Duration is more and dose
Yes.
is more. Okay.
Doses so is okay, but the same protocol of selection of the dose 225, 300, whatever, according to the BMI and the age of the patients, what we decide on. But yes, if it's a PPOS protocol, I have seen that sometimes it may go up to day 12 of the stimulation. But otherwise, in the follicular phase, even when we do the random, because like let's say it's a PCO patient, we know it's an anovulatory cycle. So usually we can start easily on day 8 or day 9 also for patients if the synchronous follicles are seen. In those patients, it's perfectly like how we start on day 2, day 3, no increase in the dose.
Yeah, in PCOS already the follicles are at the same level even in
Yeah.
day
And
8.
in fact,
So
in the poor
anybody
response
else?
or in the poor ovarian reserve, what I have felt over last 1 year is probably the luteal phase gives us a much better cohort of the follicles rather than the day 2, day 3.
Okay, so everybody
Okay,
has
so
a different
earlier we were
experience.
having discussion regarding the COCs also. So pre-treatment with estrogen or progesterone or combined or COCs or agonist, what Dr. Srimali?
Ma'am, I don't use as the oral contraceptive pills because I feel they get too much of downregulated, especially if it's a Poseidon 3 or 4 patient. And secondly, pre-treatment with estrogen, I have tried, but I have not seen too good of the result. Progesterone, again, yes, if the patient cycles is irregular and if I'm planning a day 2, day 3, then probably I'll put them on the, medroxyprogesterone, or nowadays my preferred drug is dydrogesterone in case if there's a sudden, pregnancy, it doesn't affect karke.
More
Yeah,
natural
so
one, so it's the
this
better.
was the paper I was
And
talking about.
testosterone gel and DHEA. DHEA only if the patient is willing to wait for 3 months, or if the patient is, traveling from outside and has got enough of time, then probably I will put her on DHEA. Testosterone gel, again, not so much in use. Since last 6 months, we have stopped using it, not seeing too much of benefit with it.
Okay.
So yeah, so practically speaking, it's all up to what your eye sees on the ultrasound when you feel is the right time to start the protocol and the stimulation for the patient.
So this was the paper we were talking about. This is a randomized trial to pill or not to pill, because there is controversy regarding OC pill use every time. And here also we are having different opinions with the panelists. So this paper says that when a patient is receiving pill, like for short duration, like 12 to 16 days, and if we are keeping a sufficient washout period of 5 to 7 days, there's no difference in live birth rates found between groups. And this is a randomized trial. So, and obviously so studies have shown, and even the recommendations are there, that no pre-treatment is recommended as such before any antagonist cycles. So adjuvants, anybody is using adjuvants for before
Priya,
stimulation or?
as in the last lecture, we have heard that yes, DHEA and CoQ10 works bit, but for GH, majority it is not being as a regular this thing. So we can skip on this because discussion has gone regarding this. Ceiling of the doses that can be discussed, Dr. Supriya. Any particular dose that it should not be below this and it should not be above this. Any cutoffs?
Ma'am, I personally, if I'm just using FSH, I generally start it at a dose of 225 for a patient with addition of LH, with addition of HMG of a dose of 75 if I had an experience of patient not having a proper response. So I start LH, as ma'am has told, from day 2 itself with a small dose of LH. And after day 5 or day 6, when I have an adequate response, I'll shift to the combined dosage.
So anyone is giving higher dose, more than 450, 600, like previously we used to see that our seniors used to use very high doses, especially for the poor responders. So
Preferably not more than 300. I don't start
Actually, they
more
give
than
similar
300.
results. So I think almost
Not more than
now
300.
everybody has almost shifted to
Yes.
lower between 225 to 300. Maximum 300 is those who have shown that previous cycles have not responded or so.
So, right. So many bigger studies and databases are suggesting that higher gonadotropin dose is usually not required and not recommended. So next, please, Madhu.
yeah, in this case, like we were having AFC of 7, and we have started with delayed antagonist protocol, like 3 doses of Cetrorelix was given, and with 7 initial AFCs, we gave a full throttle, like HMG 375 was started, and we could retrieve around 5 M2s and could make around 2 blastocysts, and patient were not willing for further accumulation. So we went ahead, and with this, we got a pregnancy, and she's ongoing pregnancy of around 5 months.
Okay, so we used to say that in the first few slides also, we suggested that age, BMI, AFC, these are the basic predictors, and we all know that with the increased age, maternal age, the quality of ovum gets down. So how to counsel? And this is also one fact that as the age is advancing, the requirement of the oocyte retrieval for the one euploid blastocyst is also required more. Like if the patient is over 40, so 15 or more retrieval will give you one euploid blastocyst. So you will need more and more number of the oocytes for having one normal blastocyst. So we know the impact of the maternal age, but how to counsel the patient regarding this? And as we have discussed a bit earlier, for the oocyte pooling and donor eggs, so telling them to choose one of them, how you will go for the counseling, Dr. Supriya?
Ma'am, depending on the age of the patient, we need to counsel that what would be your predictable response, and how many euploid embryos we might be able to get in single cycle stimulation. So whether the patient is willing to undergo biostimulation or consequent embryo pooling, we have to give them the option. Or even if the patient thinks she had previous IVF failures, whether she would want to opt for donor eggs or go in for third party reproductive techniques, that could also be done. That is a
So
good
that means you
option.
wish to say that depending on the how we counsel them and how they
Yes.
agree for the thing to go
Agree.
ahead,
We need
according
to
to
tell
that
them.
we can go for anything, either oocyte pooling or donor eggs, anything according to the, but they should understand that it should not always be a pressure for the donor eggs first if they are
Yes.
not willing for it.
That should
And
be the last option.
that should be
Another
the
thing-
last option, but
another
also
thing
we
is
have
there
to
are
see
many-
their pockets as well, and they should
Another
know
thing
that
is there are many modalities to check whether the baby is really aneuploidic or something. So we have to tell them that also.
yes.
We have to counsel them regarding that even if they conceive with their own eggs, there are tests available which can detect these things.
Very well said.
Yes.
Regarding
So,
now the choice of gonadotropins, addition of LH, Dr. Shimali.
Sorry, ma'am.
Regarding the choice of gonadotropins, say HMG or recombinant FSH or H addition, what is your take on that?
Yes, ma'am. So normally I prefer to use is only one drug type, not to combine too many drugs. So, but yes, if I'm using a recombinant FSH, I always believe to add a little bit of LH from start only instead of adding up on day 5, day 6. There are multiple studies which shows that, even if you add it in the middle or in the later of the cycle, sometime even it may not benefit karke. And usually they recommend that if you started with 300, there's no point of increasing the dose, around 75 or maybe 150 later in the cycle. Probably whatever has been recruited, that will only grow. So yes, I prefer to use as an FSH LH combination, but if it's a young patient less than age of the, let's say 28, with lean BMI, even the pure FSH and the dose of 200 also works well for them. But if it's an elderly patient, age more than 35, I would always prefer using an LH along with the recombinant FSH. And I do use a lot of Pergoveris, so then there's no question. It's a combination of FSH and LH along with it. So that gives a wonderful result in cases of poor ovarian response or the poor ovarian reserve patients.
Okay.
And yeah, I do also use sometimes ultraflare protocols in such patients of, with previous failure where we have not got good enough recruited cycles, then we do use the ultraflare also. But usually antagonist protocols.
Okay.
Something about endo IVF?
Anybody has tried using this protocol like Enro IVF protocol, which was in 2017, it was like pre-IVF androgenization and estrogen priming, which increases intra-ovarian androgen levels in poor responders. Not as a routine, also the evidence are limited. It has to be used only in selective patients after appropriate patient counseling. So a word about PRP and IVF. So anybody had good results with PRP injections? And what do you think? Is it really the injection or is it due to the mechanical factor which is getting into play before you expect the AFC or AMH rise? So, what are your views? Dr. Neeraj, can you highlight? Have you used PRP in any patients of poor ovarian response?
I had started using PRP 16 years back
Okay.
as a part of the pilot project when it was started in Monash University, and we did 10 cases at that time, and it was found that PRP as such was not giving any benefit as far as the outcome was concerned. And whatever little benefit in the previous studies was there was because of the mechanical
factors.
injury caused to the stroma during the injection. And this is correlated well later on when we have find out that after the pickup, the natural conception rates goes a little higher in cases of unexplained infertility. But yes, not done many, only one case I've done where we injected ovary with these stem cells. And the literature says that compared to PRP, stem cells is good for ovarian rejuvenation. But PRP till date, I have done around 60 cases and I have no shame in saying no benefit.
So the studies
And
also
we
says
followed
like
both
that.
the laparoscopic as
The
well as
larger
the
studies are
transvaginal.
also saying the same, Dr. Neeraj. We agree that no improvement in euploid blastocyst development nor pregnancy rate have been demonstrated. Few studies suggest that ovum retrieval is bit better, but the final result which we wish to have, that is almost same. So it is we agree with you. Case 3.
So with this, with this we come to the case 3, age 27 years. She is PMOS patient. Irregular cycles, AMH 7.2, AFC is 30, BMI 22. So how are you going to plan her stimulation? Dr. Supriya, in PCOS, how do you go about?
Ma'am,
Which
I
protocol?
I generally use only recombinant FSH for starting of such patients with the least dose of 150 probably, depending on the BMI of the patient. And if there's an adequate response, add an antagonist and continue with the same. I don't add LH to these patients probably in the last 2 or 3 days for final, during the time of final maturation. On those time probably I would like to add, but most of the time I continue the cycle with recombinant FSH.
So this is very well known that everybody is doing cycle segmentation. They are giving antagonist with agonist trigger and freezing, and this has become norm in all the PCOS patient right at present. So what about Dr. Veronica? Can you tell me that everybody is using only RFSH or somebody has tried with even HMG in these patients?
At times I have used not recombinant. When finances are cost, I have used HMG also.
Yes.
I have got similar good results with HMG as well, but definitely the dose has been less. I usually start with 150 HMG if it's a strict PCO patient. And cost is also a norm with recombinant FSH. And they have given almost equivalent results. So I have some experience using HMG even in PCO patients. Though technically, I also prefer to start with RFSH initially, maybe in a dose of 150 to 225, not more than that. And add only if I add HMG only if required towards the end. Otherwise, a low dose HCG also does a good this thing, ANTAC protocol. HCG, I prefer to give it in a low dose. If it's an ANTAC protocol, I prefer do a trigger.
So our panelists are agreeing on the same, and we can move bit quickly, Dr. Madhu, because
Also, this
time
trial
is.
says that HMG is non-inferior to RFSS. That can be very well
Yes,
given. Megaset
there is a
STARS
lot
trial.
of data. There is a
Yeah.
Cochrane also on this evidence that it works effectively in
Yes.
both.
Even the
is
early
also saying
pregnancy
that
loss
HMG is
has been.
equivalent.
Yes, even the early
Yes.
pregnancy loss has been shown to be less. And about the dosing, if it is an obese patient, so every time, what are the views? Dr. Neeraj, you can highlight, like every time, are we using only 150 or have you gone beyond that? Like in obese patient, we have resistant kind of PCO patients as well. So what you do?
See, I have never ever fixed up a dose based upon AMH or the weight, because
Right.
weight usually, it has been said that in obese cases we require less dose because of the risk of the OHS, but at times it is the other way around, that the
Yes.
bioavailability of the drug in obese patients is high. So in such case, we do an early check to decide whether the initial dose is sufficient, and that check is done during the recruitment phase itself. So in case if the dose is high, we can step down without compromising the quality of the oocyte. And if the dose is high, again we can reduce the dose within the period of the recruitment of the follicle, so that the risk of OHS is not there. As far as the type of gonadotrophins in such cases is concerned, I was going through the opinion of everyone. FSH and HMG both give equal result provided the bioavailability of the drugs is the same. Problem is that
The catch is here.
the technology used in FSH is such that it needs a very stringent cold chain and the supply chain system to maintain the equivalent good bioavailability.
So you have to see the results basically,
Yes.
not exactly the number that how you are giving 225 or 150 or 300. You have to see the effect of
Even
your
450 and
drug as well.
600. Even 450 and 600, not in these cases, but in poor responders, we have got very good results, even going up to 600. So still, I'm not following the literature which says that we need to freeze the dose or we should not go beyond 225 or 300. It is all Western data. All this is based upon ideally on FSH and LH pleomorphism, which we are not doing.
So
So even
basically, it is a
going
different
beyond
discussion
300 in
because
selected cases,
it
it's
is a
fine.
different discussion because here the matter is like cold chain and the
Yes.
quality. Otherwise, to come on the consensus of a higher dose ceiling, we need to see that these conditions should be equivalent. Then only we can say that
That
this
means
can
we
be the
need to be
ceiling.
individualizing each case, because
Individualized.
there can be resistant variety as well in PCOS patient. They might be obese, they might have resistant ovaries, which might need higher doses, maybe around 300 or
But
so.
we should not give the message for the generalization of a very high dose. That is also
It depends
to
on
be taken
patient's
care of.
profile and
Yes.
previous response as well.
I'm extremely sorry that I have to leave and I have an very urgent.
Thank you, Dr. Neeraj, for giving your time. We are also about to close it up. Few spot cases are also only there. The rest is to be finished by 5 minutes. Thank you so much. Thank you so much for your presence and expert opinions. GLP रिसेप्टर एगोनिस्ट सुप्रिया आजकल तो सभी लोग GLP एगोनिस्ट दे ही रहे हैं ना. So in that situation, what is your take on this regarding the obese PCOS? Continue, not to continue, stop before pregnancy. If by chance patient is taking this and got the pregnancy, what to be done?
Ma'am, I generally stop before pregnancy. I don't have much patience on which I've tried this. So I think somebody else can take up this question. I don't have much of experience
I'll
in
put a word
this.
to this. Now there are two things. One is insulin sensitivity and one is weight loss, right? Obviously, we are going to use it for PCO patients, and if weight is not a problem, what we have studies is some of our people, our doctors have also used it, which I have seen the response. And so it has been found that definitely there is a marked improvement in insulin sensitivity. But
Right.
at the same time, now the second thing is weight loss. Weight loss, yes, if you are regular with your exercise and things, it is definitely causing a good amount of weight loss. It has, I mean, even my family people have used this, but at the same time, if you stop it for some time, there is a rebound that is occurring. And the thing again goes back
And
to
the
the
dose
same
is
thing.
also different.
Yes. Second,
Dose
the
for
cost
the
is
insulin
cost is
resistance
quite
and
a
the
bit.
weight loss.
Yes,
Dose, route, cost, everything is different.
Yes, and cost is also quite a bit. It may be taxing to the patient if the patient is not very much affording. Secondly, it's a new drug. We do not know much about it and its efficacy and safety during if the patient has conceived. Rather, metformin and other
This is not a new
inositol
drug.
things
This
are
is
much.
not a new drug for insulin resistance, but yes, for the fertility point of
Yes,
view.
fertility options only I'm talking about.
Fertility point
So we
of
do
view.
not have much data about it. So we have to be
Yes.
careful if the patient gets pregnant on it. Whether we don't know whether to stop it or like metformin, earlier it was advocated give it till 12 weeks and then stop. Some people are continuing it throughout pregnancy. But safety issues has not been documented so much about this drug in fertility setups.
Yes.
So we
So the
need to be
message
a little
is
careful.
that do not prescribe solely to improve IVF success and stop
Yes.
before the conception or embryo transfer if you know that patient is taking this. And also, as you rightly pointed out, that lifestyle modification remains the cornerstone, and not only these drugs. The person is taking this, especially the semaglutide and all, they should stop it before going for the transfer and treatment. Okay. So this spot case, 30 years, married life 2 years, means a young patient but having scanty menses. FSH low, LH low, small uterus, male factor normal, still having infertility. So infertility as well as anovulation. So the Dr. Supriya or Dr. Shimali, the diagnosis of this case is?
She's case of hypo.
Hypo. And what we will prefer for her for
Ma'am,
treatment?
you can directly give her HMG where there is ratio 1:1, or you can give FSH
Yes,
with
very
LH.
right, very right. So it was a spot case. You rightly pointed out that HMG is the ideal treatment for this, and trigger LH वगैरह वो अलग से नहीं चाहिए. हाँ, recombinant FSH अकेला लेने से इस पे काम नहीं बनेगा, because if she will need both FSH and LH, or otherwise you go for the HMG. But one important thing here to mention that pre-treatment with estrogen and progesterone cyclically for 6 to 9 till the mid-cycle endometrium appears ideal for implantation, the good size of the uterus you achieve, those things to be taken care of before proceeding for the directly for the conception. So a right size of the uterus, right size of the endometrium is important to be taken care. The next spot case, Madhuprita, please can you take it?
Now we come to another case. She's 32 years with she's for IVF and AFC is 6+6. AMH is also normal. We started with HMG 300, and on day 6 you can see discordant growth of one of the follicle. So what will be your next step, like in a symmetrical type of situation? What you will do? You will increase the dose, you will keep the dose same, or what are your views on it? Dr. Kalyani.
Yeah, so I'll keep the dose same and I'll ignore the 15 mm and let it grow how it
Okay.
is growing. And I will
Very
just
right.
probably move ahead with this cohort. And if I'm using a flexible antagonist protocol, I will still, maybe I will prefer adding the antagonist maybe one day later.
Mhm.
And if I'm using a FIS protocol, then probably I would add the antagonist on this day only.
Okay, so everybody would like to keep the same dose, Dr. Veronica, like it's day 6?
Yes, I would like to continue with the same dose. So means the message is there that the largest cohort, according to that cohort, we will be going
Yeah,
rather than looking at a one larger or one smaller follicle. Actually, more or less, this after 5 days of stimulation, the size of the follicles are almost same, except for one. So I
we
don't
can
think
very
there
well
is a
ignore
point
this
in
15
changing.
mm and go
Yes.
ahead by adding antagonist, right?
Okay.
To
In
wind up,
addition to
because
hormonal assessment, any other monitoring or hormonal assessment is always required apart from ultrasound monitoring?
So
Yes,
every
or ultrasound is
Not
one of the best
I
markers
agree.
for
not
yes.
retrieving this.
So hormonal assessment is usually not required. Okay, next. Estrogen sensitive malignancy or prothrombotic cases,
This we
what
have
should be
discussed
added?
earlier.
Letrozole.
We
Okay.
need to keep the
Next,
estrogen low.
letrozole and
Dr.
LMWH
Kalyani,
if required. If required, LMWH.
Dr. Kalyani has very well summarized in the beginning of the lectures only that she is doing random start, and that can be very well done in patients facing gonadotoxic treatments, and also in fertility preservation cases. Random start protocol can very well be done.
Okay, so to conclude with this panel, we had only 3 panelists and 1 expert, but we had a very good discussion. So to conclude with, I would like to say that controlled ovarian stimulation has evolved from a uniform approach to personalized approach and selection of appropriate protocol, gonadotropin, trigger, adjuvant, ovarian reserve, age, BMI, PCOS status, and previous response. All things are important, and we have to very meticulously look upon to on aspects. The goal of modern controlled ovarian stimulation is not merely to retrieve the more oocytes, but to give a healthy baby in the lap of a patient. Advancements such as GnRH agonist protocol, agonist trigger, dual trigger, freeze-all strategies, and individualized gonadotropin dosing have significantly reduced OHSs without compromising pregnancy outcomes. So nowadays we do not see large number of cases of OHSs because of all these individual advancement of these ovarian stimulation protocol. Emerging therapies like androgen priming, GLP, AI-assisted stimulation are promising, but we need a large data for making a good database and the evidences. Ultimately, individualization, evidence-based practice, and a patient-centered care remains the cornerstones of successful IVF. So the success of controlled ovarian stimulation lies not in retrieving the greatest number of oocyte, but in achieving the right response for the right patient at right time. Thank you very much, and thank you, Madhuprita, for sharing these slides.
Thank you, everyone. Thank you so much,
Thank you.
Jaswal ma'am, everybody.
thank you, Dr.
for
Jyoti
being
and
present and for
Madhukita,
views.
everyone for
And
joining.
Thank you,
sorry,
Brijwala ma'am, as
Dr.
well.
Brijwala, it pulled little more time.
No, it's
It was a
okay
nice
because
panel,
it
huh?
was very
Very
interesting
good
discussion going on, and there were many confusing points were cleared by all of you. So thanks a lot for joining for this 3-state webinar, and we wish to keep it continue for some more webinars with all the states. Thank you
Thank you
so
so much,
Thank
all
you,
of you.
ma'am.
Thank you so much for the
much.
opportunity. Thank you so
Thank
much
you.
once again,
Thank you,
Dr.
everybody,
Brijwala
for
and Dr.
joining.
Archana Baser, madam, to bring all of us on a common platform and sharing the views. Thank you.
Thank you, Dr. Madhukita and Dr. Jyoti. It was really well conducted.
Thank you.
And Baser ma'am, before you say anything on behalf of the entire Indore team, we would request you to vote for our very dear Archana Baser ma'am for the coming Foxy presidential elections.
All
Over
the
to you,
best,
ma'am.
ma'am. All the
All
best.
the best, ma'am.
All the best, ma'am.
Thank you,
And
Madhuprita.
thanks to
Thank
Best
you,
wishes,
Bella.
Jyoti.
ma'am.
Thank you, Veronica. Thank
Wishing
you,
you the
Jyoti.
same. Best wishes. Yes, definitely.
Thank you. Thank you, Kalyani, for joining in, all of you. So let me thank all of you for joining in. It was really interesting and it's good to interact on a common platform. So thank you one and all, and thank you Sudeep ji, Format, for providing us the platform. Thank you so much.
Thank
And
you.
also
Good
Dr.
night.
Bela for conducting so well.
Yes, yes.
Thank you so much. It was
Thank you,
wonderful.
Bella, for really, conducting it so well. Thank you so much.
Thank you. All the best,
Bye.
ma'am.
Good night.
Bye.
Good night.
Bye,
Nice
Bella.
meeting you
Bye.
all. Bye.